Cardiac arrest resuscitation protocol. Cardiac arrest resuscitation is stressful, high stakes, and requires coordination/leadership. A structured approach can help smoothly lead resuscitation and rapidly identify/treat reversible causes of cardiac arrest. Perform a 5-second scan of the surrounding. Take mental note of circumstances, patient, equipment, team present. If you can't tell who is in charge, probably no one is. Take charge, set the tone. 5 seconds, I'm so and so, and I'm running this code. Initial actions, ABCDES for the code leader, the next 50 seconds. Airway, what airway do we have? Breathing, are we able to ventilate? Compressions, is CPR adequate? Who is on deck? Defibrillation rhythm, and are defib pads attached? Epinephrine, medications, do we have vascular access? Epinephrine, it is first in all ACLS algorithms, other medications, depending on rhythm. Make eye contact and ensure that someone is assigned to each crucial role. Summary/team update. Periodically, summarize the situation, interventions performed, and working diagnosis. We're on cycle 2 of a PEA arrest. Our working diagnosis is septic shock. We've given epinephrine once. Consider the differential diagnosis and potential treatments. Verbalize this thought process for team situational awareness. Diagnosis intervention. Hypoglycemia, blood glucose D50W. Hyperkalemia. Hypokalemia, ABG, calcium, insulin, D50W, others. Potassium, if potassium, 2 milliequivalent per liter. Diagnosis. Intervention. H+, acidosis. ABG, DBG. Sodium bicarbonate. Hypoxemia. ABG, DBG. Intubation, oxygenation, PEEP, etc. Hypothermia. Core temp, active rewarming. Hypovolemia. POCUS, CBC. IVF, transfusions. Code leader. The code leader is tasked with thinking and leading, but should not perform hands-on tasks. Their primary focus is on providing clear, concise direction to the team. The leader should address team members by name and have closed-loop communications. The code leader can be a physician or nurse. Delegate if needed in another role. Point-of-care ultrasound. The POCUS operator can help to identify the etiology of arrest and perform essential procedures. A protocolized exam, e.g. cause exam, should be used. Use a subxiphoid view, do not interrupt CPR. The POCUS operator should communicate findings to the team. IO access is usually the best, fastest to obtain. Effectiveness of CPR drops dramatically over time. Consider changing the person performing compressions every cycle. Have a relief person on deck. Adequate CPR achieves EtCO2 greater than 20 mm of mercury, DBP greater than 20 mm of mercury. The code leader should assess the adequacy of CPR and give feedback. Compressions. Defibrillator. Charging the defibrillator before pulse checks can shorten time to defib and reduce interruptions in CPR. Anterior/posterior placement may be more likely to achieve ROSC. While leading the resuscitation, review history, meds, and ask bedside team about context. Do not stop compressions to intubate. If unable to promptly place ETT, place a supraglottic airway. Make sure all team members are wearing appropriate PPI. Review active infusions and stop any infusions that may have contributed to arrest. Termination of efforts. EtCO2 less than 10 mm of mercury after greater than 20 minutes of CPR. Duration of arrest greater than 30 minutes without ROSC. Severe acidosis/hyperkalemia, pH less than 6.8, K greater than 10. Lack of cardiac motion on TTE, adjunct, consider family presence. Summary. Airway, definitive airway plan? Breathing, what is the EtCO2? Compressions, is CPR adequate? Defib, is patient an ACLS candidate? Medications, are specific treatment indicated? Bicarb? Glucose?